In this talk, we are going to discuss major sutures of skull, lesser sutures, how to differentiate accessory sutures or fissures from fractures, and other pitfalls that may be mistaken for skull fractures. Cranial sutures are syndesmosis between cranial bones. A syndesmosis is a fibrous joint between two bones. There are four major sutures of the skull: the metopic, also known as the frontal suture, sagittal suture, coronal suture, and lambdoid suture. Patent or obliterated suture can be attributed to the presence or lack of physical force on the skull bones. First, let's discuss the metopic suture. The metopic suture is also known as the frontal suture. It lies between the two parts of frontal bone. The metopic suture may begin to fuse in utero. The metopic suture fuses and is obscured by 1 year of age in most patients. However, it may not close until adulthood in up to 10% of patients. Looking at these images, you can easily see how the metopic suture might be mistaken for a fracture in somebody who is not familiar with this suture. In some cases, the metopic suture persists as complete or incomplete suture, extending from the nasion to the anterior angle of the bregma. This condition is referred to as metopism or sutura frontalis persistens, and it is important not to mistake this entity for an anterior vertical fracture. This is 3-year-old boy with frontal head trauma. As you can see, there is frontal soft tissue swelling with underlying vertical bone lucency. If you look carefully at this lucency, typically, it is at the exact location of the metopic suture. It shows zigzag interdigitating sclerotic border, typical for persistent metopic suture, which was initially diagnosed as a fracture. Coronal suture. The coronal suture is oblique in direction and extends between the frontal and the parietal bones. The coronal suture extends towards the apex of the skull and meets the sagittal suture. This point is called the bregma and indicates the position of the anterior fontanelle. The coronal suture extends towards the base of skull to the terion. The terion is the area where four bones, the parietal, the frontal, the sphenoid, and the squamous part of the temporal bone, approach each other. The average width of coronal suture at birth is 2.5 millimeters, narrowing significantly to 1.3 millimeters by 1 month of age. Like the sagittal suture, the coronal suture remains unfused throughout childhood. Typically, the suture will close and fuse around age 24. Rarely, the coronal suture may close in utero, or prematurely. This can be either unilateral or bilateral in craniosynostosis, and may be associated with distortion of the orbits, causing deformity known as Harlequin eye deformity, and a foreshortened skull vault known as brachycephaly. Harlequin eye deformity is characterized by elevation of the supero-lateral corner of the orbit, and it may be seen in unilateral or bilateral coronal suture synostosis. The coronal suture is one of the three sutures whose junction forms the anterior fontanelle. The anterior fontanelle originates at the intersection of the frontal suture, the coronal suture, and the sagittal suture. This fontanelle is open at birth and generally fuses around 18 to 24 months after birth. Sagittal suture. The sagittal suture is located between the two parietal bones. It intersects with the coronal suture anteriorly at the anatomic landmark known as the bregma. The average width of the sagittal suture at birth is 5 mm, narrowing significantly to 2.4 mm by 1 month of age, and narrowing further over time. The sagittal suture starts to close at 21 to 30 years of age, beginning at the point of intersection with the lambdoid suture, and fusing anteriorly. If the sagittal suture closes prematurely, the skull becomes long, narrow, and wedge-shaped, a condition known as scaphocephaly. The sagittal suture is the suture most commonly involved in craniosynostosis. Lambdoid suture. The lambdoid suture separates the parietal bone from the occipital bone. The inferior extension of the lambdoid suture is the occipitomastoid suture. The lambdoid suture remains open during childhood, typically closing by 26 years of age, and is the most common site of Wormian bones. The lambdoid suture is more likely to remain open and less likely to be obliterated than the sagittal or coronal suture. Squamosal suture. The squamosal suture separates the parietal bones from the squamous portion of the temporal bones. To understand the squamosal suture, you should first understand the terion. The terion is the point where the frontal, parietal, temporal, and sphenoid bones meet. The squamosal suture is composed of two segments: the temporosquamosal suture and sphenosquamosal suture. The temporosquamosal suture arches posteriorly from the terion and separates the squama of the temporal bone from the lower border of the parietal bone. This suture is horizontally oriented and difficult to visualize in axial cuts. This suture is continuous posterior with the short and nearly horizontal parietomastoid suture. The sphenosquamosal suture courses inferiorly from the terion and separates the sphenoid bone from the squama of the temporal bone. This suture is vertically oriented and often mistaken for a skull base fracture. Occipitomastoid suture. The occipitomastoid suture extends between the occipital bone and mastoid process of the temporal bone. This suture is a continuation of the lambdoid suture and extends inferior to the base of the skull. Not infrequently, the occipitomastoid suture may be mistaken for a skull base fracture. Knowledge of the superior continuation of the occipitomastoid suture, along with the presence of a second symmetric occipitomastoid suture at the base of the skull, are helpful in differentiating this suture from a fracture. Sphenofrontal suture. The sphenofrontal suture is a transverse suture between the anterior margin of the lesser wing of the sphenoid bone and the posterior margin of the horizontal orbital plate. This suture is often difficult to visualize because it courses horizontal. The sphenofrontal suture is easier to see in young patients less than 6 months of age, when the suture is wide. After 6 months, the suture becomes narrower and starts to fuse, which makes visualization more difficult. The lesser wing of the sphenoid bone, posterior to the suture, is a useful landmark for suture localization. Suture closure starts at the lateral aspect. Mendoza suture. The Mendoza suture, also known as the accessory occipital suture. It is a remnant of transverse occipital suture. This suture often closes in utero or in the first few days of life. Mindusal suture fuses and is obscured by 6 years of age in most patients. The occipital bone develops from 6 ossification centers, so that any defect in the ossification process can give rise to the Mindusal suture. On axial images, the Mindusal suture is seen medial to the lambdoid suture. Midline interparietal suture or superior median suture. It is accessory suture at the upper part of the occipital bone that wedges between the parietal bones. This part of bone is called the interparietal bone. This suture extending 2 to 3 centimeters in the occipital bone, but not to the center of occipital bone. Interparietal bone. It is a large, single intrasutural bone at the junction of the lambdoid suture and sagittal suture. This reflects anomalous fusion or separation of the ossification centers of the interparietal portion of the occipital bone. This interparietal bone and surrounding sutures should not be misinterpreted as fractures. Midline occipital fissure. There is a defect in the posterior aspect of the occipital bone, near the foramen magnum. That is a normal embryologic defect. If this persists, it gives midline occipital fissure. It extends from the dorsal aspect of the foramen magnum. This fissure is normally less than 1 to 2 centimeters in length, and appears white and sharp. If you see a line beyond 2 centimeters, it is not normal fissure, it is a fracture. Is this a fracture or suture? As you can see, there is a linear lucency in the occipital bone in the exact same location of the midline occipital fissure, but it extending 3 centimeters from the dorsal lip of the foramen magnum. This lucency tends to be wider as it approaching the foramen magnum. This is a fracture, not a suture. Anterior and posterior intraoccipital synchondroses. The anterior and posterior intraoccipital synchondroses fuse the basilar portions of the occipital bone. Particularly the posterior intraoccipital synchondrosis has sharp, well-defined course. And if you have a oblique image, you can easily mistake this for a fracture. The anterior and posterior intraoccipital synchondroses usually fuse in early childhood, starting at about 1 to 2 years, and they are usually completed by 7 to 10 years. Accessory parietal sutures. Accessory sutures are most commonly found in the parietal and occipital bones because of the multiple ossification centers of these bones. Accessory parietal sutures are the most common accessory sutures. It results from incomplete union of the 2 ossification centers. Accessory sutures are usually bilateral and symmetric. They are seen as small fissures very common in the posterior parietal bone, and usually extending anteriorly from the lambdoid suture. They are frequently multiple, most commonly seen in infants less than 2 months of age, and disappear by 6 months of age. Parietal bone fractures are the most common fractures in the pediatric population. The use of 3D CT imaging can be helpful in assessing the parietal and occipital bones, and distinguishing fractures from accessory sutures. Is this a fracture or accessory parietal suture? As you can see, there is a linear lucency in the parietal bone in the exact same location of the accessory parietal suture. This lucency tends to be wider as it approaching the lambdoid suture. This is fracture, not accessory suture. Fractures versus sutures. Fractures have sharp non-sclerotic borders, but sutures tend to have zigzag, interdigitating sclerotic borders. Fractures can cross sutures, but sutures do not cross other sutures. Fractures tend to increase in diameter as it approaches suture, while sutures have uniform thickness. Look for secondary signs in fractures, whether overlying soft tissue swelling or underlying hematoma. Wormian bones. Wormian bones are accessory bones that occur within sutures, most commonly in the posterior sutures. They are considered normal variants, but if more than 10 Wormian bones are present, the presence of an underlying pathologic process should be considered. In the following quiz cases, each case will be displayed for 25 seconds. After that, the answer will be displayed.